Welcome to Ideas in Action, the official University of Southern California podcast. Shows are webcast live on Facebook from Studio 1A in the USC Annenberg School for Communication and Journalism.
Welcome to the University of Southern California, Facebook Live from Studio A. My name is Ricky Bluethenthal. I'm a professor in the Department of Preventive Medicine in the Keck School of Medicine at USC and also Associate Dean for Social Justice in the Medical School. And I'm here with...
Hi, I'm Jason Doctor, and I'm faculty at the Schaefer Center for Health Economics and Policy.
So every day we confronted with tragic outcomes of the opiate crisis, including a staggering number of overdose deaths, 130 a day. But we understand more and more about the epidemic every day, and there's reasons to be hopeful. Can you talk about how it started?
Sure. So back in the mid-90s, opioids were prescribed rarely for chronic pain, almost never. There were a few patients on a drug called methadone for pain. But then researchers started working on what are called long-acting opioids, which stay in your system for 8, 10, 12 hours. And along with, there was a drug called OxyContin that was developed by Purdue Pharma. That drug was aggressively marketed to physicians. They were told that the drug, with some FDA approval, that the drug was less addictive. And so physicians, many of whom didn't have good resources for dealing with chronic pain, began prescribing OxyContin in high doses. People became dependent on the drug. There was also a liberalization in general around opioids, as even short-acting opioids in the emergency department and other places. So people started to get opioids stockpiled in their medicine cabinets, and then kids and adolescents and young adults began to use opioids at parties. So there was just this kind of reservoir of opioids that has kind of built up over the years.
Yeah. As someone who studies drug use epidemiology, a couple of things jump out to me about the particular crisis that we're in now. So one is that it's national.
Right.
I mean, typically we've had drug use epidemiological problems that are pretty specific, though, like crack cocaine in urban centers or methamphetamines in sort of rural environments and suburban settings. But this has really reached everyone, and it's really taxed the system in ways that we weren't prepared for, and that are causing lots of downstream problems. Another thing I think is that in our efforts to try and wrangle the epidemic, we've sometimes implemented solutions that create other sort of downstream problems. So one of the things I've studied is the sort of transition of opiate use to heroin use, and now we're in a circumstance where the heroin supply has now become contaminated with a synthetic opiate, fentanyl.
Can you tell us a little bit about that? How do people go? I imagine people don't wake up one day and say, I'm going to inject heroin. This is a process. And can you tell us a little bit about the risk factors?
Yeah, well, I mean, I think, there's that interesting book by Sam Quinones who sort of talks about the development of a national heroin supply and the sort of cartels that were involved, an individual involved in making that happen. But I think basically what happens is that there's a sort of this idea of iron law of prohibition. And so in a way, prescription opiates have now been prohibited. And so what ends up happening is they're then replaced by substances that are more potent and less expensive, which is sort of what happened with alcohol prohibition previously. And so heroin was the first step in that. And as there's sort of a demand and the market response to that, people get access to it. And the more people have access to it, the more people have access to it, right? Because it's a social network thing. And then if you're a drug trafficker, you realize, all right, so I'm making a ton of money with heroin. Well, here's this fentanyl, the fentanyl, which is, 10 or 50 or 100 times more potent than heroin.
Right.
And so it's easier to import or smuggle, and so now that's contaminated the drug supply, on some West Coast cities like Vancouver, the Midwest, and lots of places on the East Coast, and now increasingly in Los Angeles and San Francisco.
Wouldn't you say that the heroin problem actually started to rise before prescription drugs were prohibited also? Not to say that prescription drugs, that restricting them might contribute to switching, but that the cost of heroin was so much less And you mentioned these cartels and how they developed these networks that made it so easy and inexpensive to get heroin.
Yeah, no, I think that's absolutely true. So the uptake began in the late 2000s,
right?
And then you see a notable increase in later years. I mean, we have really poor surveillance techniques for monitoring heroin use.
Right.
You know, we sort of this national household survey. But, you know, in my studies, for instance, which are with mostly homeless, chronic heroin users, the homelessness rate went from 30% in the early 2000s to 80%, 90% now. So they're not going to be in our traditional surveillance.
Right.
So can you talk about a little bit what's happened on the doctor side, and what do we know about their efforts to sort of pull back? And what
Sure, absolutely. So, you know, one way I got interested in this research as a behavioral economist, that means I study people's behavior. And I was curious as to why we had these rising deaths, just a tremendous number of deaths. And up until around 2011, we just had increased prescribing. Prescribing didn't go down. After 2011, it started to plateau, and then it slowly went down to about 25% reduction from where it was at its peak. But I was kind of curious, why would physicians continue to prescribe opioids at high rates when they're watching the news? They're seeing, you know, people dying in their cars. They're seeing people saying, I got this drug from my doctor. That's how I got started on this. And it occurred to me that, you know, one of the reasons might be that doctors are not seeing the patients who have bad outcomes. And we call that survivorship bias. What that means is that, you know, if you're treating patients, you're more likely to see someone come back who's doing well on opioids. You're going to see someone who just wants a refill. If you become addicted, there's a lot of stigma associated with addiction. You might go to a rehab center. You might go to an addiction specialist. But you might not go back to your doctor. If you die of an opioid overdose and you received opioids originally in the emergency room, you definitely wouldn't know about it. If you have a primary care doctor, then, you know, that doctor treats about 5,000 patients panel that they see, you know, any given year, and they may just not notice that you're no longer around. And so we thought that maybe we could improve safe prescribing by getting doctors information that they need about harmful outcomes, just clinical information about their own patients. What happened? This person died, and we found that when we did that, we observed a 10% reduction in their opioid prescribing, and we did not see abrupt drops in opioid prescribing, which was good. Mm-hmm. We saw that it was gradual, but that doctors were taking more care and were more concerned about the potential harms of opioids.
Well, you know, one of the you know, this is such a complex issue, and one of the things that really makes it difficult to get a handle on is the fact that most of us can use opiates without a problem. Like, even with the massive availability, it isn't really a problem for most people. It really just, it's sort of a thing where folks who have a propensity or get exposed and it really hits their button, then it becomes hard to control. And we see that a lot. Like, one of the things that we've observed in my studies is, you know, how rapidly people's drug use escalates once they move from opiates to heroin, and the use pattern gets pretty intense. They often then transition to injection for economic reasons again, because heroin is ridiculously inexpensive. So basically, in my typical study, people can get by on $20 or $30 a day of heroin, when if you were to buy a prescription opiate pill in the street market, it'd be $90 or $100.
I just thinking about that issue of who gets addicted, and, you know, it really is a continuum. If you look at people who have surgery who are opioid naive, meaning they've never had an opioid before, or go to the ED for an ankle sprain, they've never had an opioid. You know, somewhere between 7 to 13% of those people who had an acute pain problem that should have resolved will be on opioids 3-6 months, even a year later. And often when you look at their medical claims, they're coming back in for other pain problems. So they've developed kind of a taste for opioids because they've been exposed to it. And then the other people are not dependent on opioids or don't use it long term. 1 in 4 people can't even tolerate opioids.
Right.
So but if you're deciding to distribute opioids to everyone, you're going to get a large absolute number of people who eventually become dependent, and even a sizable number who become addicted.
Yeah, I call that the denominator problem.
Yeah.
So you've increased typically, and so for years in my study, so I've been studying community-based people who inject drugs, mostly heroin, meth users, since 1991. Mm-hmm. And I started in my 20s. So the people I was seeing were aging with me. And now that stopped. So about 10 years ago, it stopped, and now they're getting younger. Mm-hmm. And some of that is because of this new cohort of people. And we were sort of like, where are these people coming from?
Right. So you saw a group of people from prior to the opioids crisis who were addicted to heroin, and then all of a sudden you started to see younger people coming in large numbers, and this is the denominator problem you're talking about.
That's right. Right. We've sort of introduced a whole new cohort of people to these medications.
So one thing that interests me about your research is this idea of short-term goals and long-term goals. So obviously a long-term goal is to help people recover from addiction, but a shorter-term goal is to help them use drugs more safely so that they don't have health ailments associated with those problems, and that's called harm reduction. Maybe you can tell me a little bit about what you do and what sort of benefits people get from that.
Yeah, well, I think in the United States context, it's important to put harm reduction in the sort of the temporal context when it emerged. So it came out of the HIV epidemic, and some people will recall that in the late 80s, the second largest group that was getting HIV in the United States were people who injected drugs. And you had populations, or you had people in urban settings like New York City, Boston, New Haven that were reporting, or Hartford rather, that were reporting very high rates of HIV in their populations of injection drug users. And so at that point, HIV was terminal, right? There was no cure yet. It was also easy to transmit. So you sort of have a choice, right? You can either do nothing, or you can begin to develop non-judgmental, practical strategies that reach people where they're at and try and get that sort of short-term or incremental or any positive change that's going to sustain their life until either we bring in other resources that give them other pathways and other choices, or they make the decision that, hey, I'm not going to do this anymore, and then they find their own way out. And so that's sort of what harm reduction is about. The quintessential example of that in the United States has been the syringe exchange programs, which operate on the idea that we're removing dirty syringes out of circulation and destroying them appropriately, but then giving people enough syringes so that they won't have to share. And so I did some research on that, about 12 years ago, where we really demonstrated, I think convincingly, that the more syringes you make available to people, the less likely they are to share syringes, the less likely they are to give used syringes to other people. And you can do that without making syringe disposal problems worse.
What can happen to you if you use a syringe that's not clean?
So you can get HIV. I mean, more commonly, you'll get hepatitis C. But you can be also exposed, obviously, to other bacteria and flora that are gonna make you sick. And, one of the things that's happened that we haven't talked a lot about in the national conversation around opiates is this transition to injection drug use. And that sort of happens pretty rapidly in the folks that I see, and the sort of drivers behind that again are economics. So a $10 bag of heroin, if injected, will last you 6 or 7 hours. If you use it through some other means, it's not going to last as long. And so we're seeing lots of evidence in the sort of hospitalization data and other epidemiological data that speak to the fact that we have more injection drug use going on in the United States. So we have an acute hepatitis C epidemic going on. We've had enormous increases in hospitalizations due to abscesses or skin and soft tissue infections. There's a growing injection-related infective endocarditis crisis.
Endocarditis meaning your heart has an infection?
Yes, exactly. And that comes from injecting almost exclusively, right? And so if you have an unhygienic injection, you're going to introduce these bacteria, they'll undermine the walling of your heart, and then you'll have a whole set of other problems.
You might need a new heart valve, or
it's an emerging issue, I think. And And then the other thing is, again, getting back to this cohort piece. So in California, the California Department of Public Health has actually generated some interesting data about acute hepatitis C infection. And there's sort of two things that jump out about it. And this gets a little bit back to that geography question. So there's a hepatitis C epidemic happening in California, but it's actually happening in the rural parts of the state. In northern, you're seeing huge growth in the Central Valley, in the far reaches of northern California.
That's also where opioid prescribing was the highest.
Exactly. So you have that, and then the other thing is that the population profile of hepatitis C in California used to be a camel, right? So people my age, perhaps your age,
I think we're about the same age.
We're in the sweet spot for having hepatitis C, and now it's a two hump camel. With a younger cohort of people bulging up because of the spread of injection drug use, and then the hepatitis C, which is very easily transmitted.
I think that geography question that you brought up is something that makes it really difficult to talk about the opioids crisis with people, because it is so specific to different places. If you look, and you mentioned fentanyl, which is a very powerful opioid that's manufactured illegally in China. It's also used for legitimate medical purposes. But that's been driving a lot of the recent deaths in large number. And if you look state by state, you see that fentanyl is fairly confined to a number of states in the Midwest and on the East Coast. It hasn't moved west as much, and that prescription drugs are still a big problem in states like Oklahoma, California, Utah. So when you're talking to someone, they say, oh, well, now it's a fentanyl crisis. It's sort of like, well, it is, but it's a fentanyl crisis in Ohio. It's a prescription drug crisis in Oklahoma and in California. Yeah. And we obviously have to address all legitimate and illegitimate uses, but it's not easy to talk about this as there's no quick fix or one story here.
Well, I mean, I wonder, because you do a lot of policy research. I mean, do we have other examples where you have sort of a widespread problem that has multiple kinds of manifestation? And are there any like rules of the road about how you construct a policy that that deals with that kind of problem?
Well, I think the policy has to be at the state and local level mostly. You have to work with counties. We're working with LA County right now, and if you want to make a difference on a local level, you have to work with the county, try to get the county board to put forward a motion to make some change, and then that means that the CEO of the county can really take action. And we did that with this Letters project, which informed physicians of of a patient in their practice who died of an opioid overdose. And the county came forward with a motion, and then now the medical examiner sends letters that are non-judgmental, just informative and giving some tips and guidelines for how to prescribe opioids more safely. So I think you have to deal with it on a county-by-county basis, particularly in the U.S. when everything is so balkanized in terms of information. So we have a lot of inefficiencies in our healthcare system. Not only are they monetary, they're also informational. So we don't have a unified electronic health record where we can look up and say, oh, what happened to so-and-so? You have to look within a health system, you have to look within a prescription drug monitoring database for a state. So I think just not thinking about the problem on a national level helps in looking for local solutions. California's done a good job, I think, also with preventing fentanyl from coming into the state through resources and access to buprenorphine, which is a treatment for opioid addiction. Anyway, those are my thoughts. Do you have any additional?
Well, I mean, I think that, one of the interesting things for me is we think about parts of the solution in buprenorphine or Suboxone or Subutex is, we have these national regulations and then even national models that that both make a problem for everybody, right? So having to do this additional training to be able to prescribe buprenorphine. But then the model, which is based on having primary care physicians be the primary conduit, is probably mistaken. It's probably not the best way to get these medications out. And some of that is just from a business planning perspective. I mean, earlier in this conversation, you pointed out that a typical primary care physician would have a patient panel of 5,000 people. Well, who wants to introduce a couple of hundred people who have pretty serious substance use challenges or opiate use disorder, are going to be maybe inconsistent for a whole variety of social determinants of health reasons.
And you have a 15-minute visit.
And you have a 15-minute visit. Like, it's probably not, it's a national approach that probably doesn't make sense given, at least in California. I mean, the primary care physicians I know, no one has space. Right? The community clinics, nobody has space. And so what we've done, and I've seen this over the course of my almost 30-year career, we have to reckon with the fact that we've never made it easy for people to get the medications they need to stop using opiates. We've never made it easy. And we need to really work on that, creating a system where someone says, and someone in my study says, hey, Ricky, I'm ready to stop. And I can say, great, we're going to walk you down the street. You'll see the doctor, and we'll get you started on Suboxone or Subutex or Vivitrol or Methadone. And they're very strong medications. I mean, they really do work. They have great evidence, but we haven't created that social or service infrastructure to actually make that a possibility.
Maybe we should talk a little bit about medication-assisted therapy and how people would go about stopping opioids, or not necessarily stopping, but changing to a different type of opioid that might allow them to be more functional in their life. People don't, everyday folks don't always learn about these different medication-assisted therapies and what they are. You mentioned buprenorphine and Vivitrol and Methadone, and each is very different in terms of how it's delivered. I think buprenorphine, you can actually take it home with you, whereas Methadone, you have to go to a clinic. And there are a lot of barriers. I've always characterized these two barriers as there's sort of a social stigma barrier, and then there's a sort of structural barrier. And so the structural barriers are, where do I go to do this? Like, no one has told me, and my doctor doesn't know where I can get treatment. And then the stigma barriers are, as much as I study overprescribing, there's an underprescribing problem when it comes to buprenorphine, that we're not getting enough buprenorphine to people who need it. And a lot of that, I hate to say it, but some of that at least has to do with stigma. The these are patients who can be difficult sometimes to work with, and as you mentioned, it's challenging to think bringing 200 patients into your practice if you've got a full practice. Often patients, when they're addicted to drugs, might do things that would make us feel uncomfortable or feel like we can't trust them, and that's part of the disease of addiction. Yet that can also mean that some physicians are a little reluctant to prescribe if they are worried that someone might sell the buprenorphine to someone else or do other things. I don't know. Do you have any ideas about how we overcome those barriers? Because we're not going to solve the problem unless we do overcome them.
Well, I mean, the buprenorphine medication is pretty perfect. And what I mean by that is that, it can be taken in a variety of doses that last anywhere from 8 hours to 36 hours almost, depending on how you want to go. They don't have a high impairment profile. So very shortly after taking it, you're going to be, back to whatever state you were in.
It's an opioid, right? But it's an opioid that it doesn't bind the same way other opioid does to your receptors in your brain, so it sort of prevents the euphoric effects. And you can't really...
And you can't use over it either.
You can't use other opioids that would create a high when you're on buprenorphine.
Which is not the case, say, with methadone. So, I do think, there's an opportunity there. Speaking of the structural problem, though, I mean, our whole healthcare system isn't very flexible. And I don't know if you and I have had this conversation, but, it works great for people like us. So if we need to go to the doctor, or if I need to stop working to take one of my kids, or my wife needs to go, I just stop and I go. And I get paid the same amount of money I was going to get paid. I lose some productivity, but, the doctor sees me pretty quickly. It's all easy peasy. And then there's another group of people who maybe aren't as well compensated as you and I are, where there are other struggles and they work for people. And so, there are other complications that make it tough. But there's a whole nother group of people who are hourly wage workers or people who don't have jobs at all, where the system, or they have these substance use challenges, the system can't serve them at all.
Right.
They're essentially untreated, both because the cost of getting health care is too expensive for them, the opportunity costs, again.
Right.
So if I'm not working, then I'm not making money. If I'm
they
not
can't
making
get to
money,
the appointment.
they can't get to the appointment, or if I don't work today, I can't feed my family.
Right.
And so we have to begin to sensitize ourselves to the fact that if we want population health outcomes, we have to take into account the whole population, and not the middle class or upper middle class people who've done well in this competition, and have a system that actually works pretty well for us. Do you have any thoughts about? I know there's a lot of drama, and there's been a lot of work in economics around cannabis.
Oh, yes.
What is it doing or not doing?
Right.
Does anyone really know?
Right. So, so the one big question is whether cannabis we should just say, hey, let's give everybody cannabis instead of opioids, and will that solve the opioids crisis? One thing that economists study is this principle called adverse selection. And you're saying, what is adverse selection? Well, that means that we don't control who decides to take what treatment. So when we study this stuff, we find that people might select into using opioids. And a lot of times people who select into using opioids have, for a long time, in high doses, they tend to have other life traumas. They might have been abused. They might have depression. They might have a substance use disorder. And they're not only taking opioids, they're taking benzodiazepines, which is an anti-anxiety drug. They're drinking alcohol. They're using cannabis too. So it's hard to study whether, with observational data, whether cannabis actually improves pain, because what you find is you have this large group of people. It's more comfortable also to talk to your doctor about physical pain than it is to talk about psychological pain. Right. And you do feel physical pain when you have psychological pain. So often they'll go into their doctor and say, doctor, I've got this pain problem. So what we see is that people who are using cannabis, new data is coming out showing that they also tend to use opioids in high amounts. Mm-hmm. That doesn't mean that cannabis use causes opioid use. It also doesn't mean that cannabis maybe offers some analgesic effect. It just means that we have this group of people that we're not really addressing that have some of these life traumas and psychological problems that are sort of driving this high use of drugs in general.
Yeah, I mean, I think the other problem we have is the medication profiles even. So even though we have good medications for opiates, we don't have good medications for the other drugs in terms of methamphetamines,
right,
cocaine, alcohol even, really. And so there are real limits on the way we use medication. I mean, I have a study now when we're looking in an observational fashion at whether cannabis use might interact with opiates in a way that maybe reduces opiate use. So we'll have inconclusive findings to share. Let's talk a little bit, just finish up since we only have a couple minutes left, on solutions. And I didn't want to miss this opportunity to talk a little bit about safe consumption sites,
yes,
which I know can be very controversial. But I think they're also a part of a multi-level, multi-pronged solution. So, we talked, hopefully you've been sensitized to the idea, and I know you have, that we have diverse patient populations. And so for some of these folks, things like safe drug supply, where you're prescribing heroin, or having locations where people can go and use drugs, be monitored, use them in a way that's not going to spread HIV, hepatitis C, it's going to reduce their chances of getting hepatitis or abscesses, and then they're going to be monitored so that they don't, so if they have an overdose, there'll be appropriate medical response. I really do feel like we have to begin using that in the United States. There are hundreds of these throughout the world. No one's ever died in one of them. And sort of not using them is kind of like going into a boxing match and deciding I'm only going to use my right hand.
Right. Do you think it's hard to measure outcomes for safe consumption sites? Because the kind of things that you're describing are sort of very broad and difficult to measure, but sort of common sense reasons why safe prescribing sites would be good. Mm-hmm. That you brought it up earlier, these people don't have any other place to go. They can't interface with the healthcare system. They don't have the time or money. They may be foggy because of addiction, and this gives them a place to go where they can get maybe not comprehensive services, but a safe place to use drugs. They can also maybe get some help, social work and other things. Is that harder to measure? Those benefits harder to measure than sort of harder benefits about use and what happens to these people? I mean, why is there a controversy? Is it a measurement controversy?
Well, I think it's a political will controversy. Mm-hmm. We do interventions all the time that don't work and have no reasonable expectation. Look, we just spent 40 years putting people in jail for substance use problems.
Right. Didn't work.
And it didn't work. So I think there are challenges there. But if we're interested in actually authentically helping the population, I think that has to be part of the response. Well, thank you for joining me, Jason.
Thank you.
It's been fantastic. And thanks for joining us in Studio A. Have a great day.
Thanks for listening. Be sure to subscribe to our podcast and visit us at podcast.usc.edu.